In sleep medicine, there are a few skills that are just absolutely critical, and titrating supplemental oxygen during a sleep study is right at the top of that list. So today, we're going to break down the official evidence-based protocol from the American Academy of Sleep Medicine, or AASM. And let's be really clear here, this is about so much more than just passing an exam. It's all about keeping patients safe. All right, so here's our game plan. We're going to start with a number one absolute first rule of this whole process, and that's the patient's airway. Then we'll get into the specific trigger that tells you it's time to start oxygen. After that, we'll walk through the titration protocol itself, define that crucial target zone you're aiming for, and then we'll wrap it all up with the essentials of setup, safety, and documentation. Okay, so picture this. You're a sleep tech, you're monitoring a patient on PAP therapy, and all of a sudden, you see their oxygen saturation just plummet. That gut instinct might be to just reach over and crank up the oxygen, right? But hold on. Is that really the right move? What is the very first thing you should be doing?
Well, the answer comes down to a core principle of sleep medicine, and it's captured perfectly in this one little phrase. Oxygen doesn't move a collapsed tongue. Seriously, this one idea right here guides every single thing that comes next. And that brings us right into section 1, the first rule, which is all about the airway. Look, the protocol is crystal clear on this. Before you even think about adding a drop of oxygen, you have to, absolutely must, fix the obstruction first.
So here's the deal. If a patient's oxygen is dropping because of an obstructive apnea, the real problem is a physical blockage. It's like a roadblock, and you can't just pump oxygen through a roadblock. It's not going to work. The only correct first move is to adjust the PAP pressure and get that airway open again. This means we have to totally shift our mindset. We've got to stop seeing oxygen as some kind of generic safety net we can just throw at any problem. We have to start treating it for what it is, a drug. It's a precise medication, and it has to be given according to a very strict, evidence-based protocol. Okay, so we've established that the airway has to be clear first. Now we can move on to section 2, the trigger. When exactly do you get the green light to start oxygen therapy? Well, the AASM gives us a super specific benchmark, 88% for 5 minutes. And here's exactly how that sequence plays out. First, you confirm the patient's airway is open and stable with their PAP therapy. Only then, if their SpO2 drops to 88% or lower, and it stays there for 5 straight continuous minutes, then and only then have you met the trigger to start the supplemental oxygen. Now, you might be asking, why 5 minutes? Why not 1 minute or 30 seconds? Well, that 5-minute window is absolutely crucial. It keeps us from overreacting and treating these little temporary dips in oxygen that can happen for all sorts of reasons, like the patient going into REM sleep or even just rolling over and jostling the sensor. That 5 minutes proves the need is real and persistent. Okay, so the trigger has been met. You've got an open airway, but the patient has been sitting at or below 88% saturation for more than 5 minutes. What now? Well, let's walk through section 3, the titration protocol. This is your step-by-step guide to doing this safely. And the protocol is very methodical, very patient. Step 1, you start the flow at exactly 1.0 liters per minute. Not 2, not 1.5, start at 1. Then, step 2, you wait. You have to give it a minimum of 15 minutes to see what happens. And only after that long wait, if the oxygen level is still too low, do you move to step 3, increasing the flow, again, in small 1.0 liter per minute steps. So what's with the 15-minute wait? It sounds like a long time, right? But it's not some random number. That time is so important because it allows the patient's blood gas levels to stabilize and reach what we call a steady state. It basically ensures that the number you're seeing on the monitor is the real number, so you're not just chasing these fluctuating readings up and down all night. So we're slowly, carefully increasing that oxygen flow every 15 minutes. But what's the goal? What number are we actually aiming for? That brings us to section 4, the 90 to 94% target zone. This is what you could call the clinical sweet spot. The whole idea here is to find this a very precise balance. Anything below 90%, well, that's the danger zone of hypoxemia. But, and this is so important, anything above 94%, you're actually entering a risk zone for other problems. The entire point of this careful titration is to gently guide the patient right into that sweet spot, that target zone of 90 to 94%. This brings up a really common question. I mean, if some oxygen is good for the patient, why isn't more oxygen even better?
Why don't we just turn it up, aim for 100% saturation, and be extra safe? The answer actually lies in our own body's wiring. See, for most of us, the signal that tells our brain to take a breath is rising carbon dioxide in our blood. But for some patients, especially those with conditions like COPD or obesity hypoventilation syndrome, that system is kind of broken. Their backup signal is low oxygen. So if you give them too much oxygen, you effectively turn off their only signal to breathe. And that, as you can imagine, is incredibly dangerous. All right, we've covered the why and the how of the protocol. Let's finish up with the nitty-gritty practical stuff in Section 5, setup, safety, and documentation. These are the hands-on essentials you just can't afford to forget. When it comes to setup, the oxygen has to be bled directly into the CPAP circuit itself. You do this with a little T adapter or a special port that's built right into some masks. Here's the one thing you can never, ever do. Just tuck a regular nasal cannula under the patient's CPAP mask. I know it seems like an easy fix, but it's a huge mistake. It completely ruins the mask seal, which causes leaks and means your pressure readings are totally wrong. Now, for safety, the gold standard, the absolute best practice, is to monitor the patient with capnography, which measures the carbon dioxide they're breathing out. If you see a big sustained rise in their end-tidal CO2, that is a major red flag. It's telling you that the extra oxygen might be causing that blunted respiratory drive we just talked about. And last, but definitely not least, documentation. You've heard the old saying, if you didn't write it down, it never happened. And it's so true here. Every single time you touch that oxygen flow meter, you have to log it. Note the time, note the PAP pressure, note the new flow rate, and note the patient's oxygen level that resulted from that change. This is non-negotiable for both good patient care and for your own legal protection.
So let's boil this all down into a quick little cheat sheet. Rule number 1, obstruction, you fix it with PAP first. The trigger, an SpO2 at or below 88% for 5 straight minutes. Your starting flow, always 1.0 liter per minute. Your increases, 1.0 liter per minute every 15 minutes. And your target goal, you're always trying to keep that SpO2 right between 90 and 94%.
You know, following these rules is obviously about way more than just passing a test or checking off a box on a form. It's a precise scientific protocol that's built from the ground up entirely around patient safety. It really makes you think, when is a protocol more than just a rule? I think it's when it becomes the standard of care that protects both the person you're caring for and you, the clinician.